Good afternoon. Welcome to another exciting session of 108 Harley Street CPD Snippets. Today I'm going to be talking to you about hyperhidrosis. Hyperhidrosis is an embarrassing, difficult condition which I think is commoner than what we encounter in clinical practice. As always, if you have any questions, comments or feedback, please drop me a line at this email address on your screens at the moment, and I will get back to you promptly. So, what is hyperhidrosis? Hyperhidrosis literally means excessive sweating. It can be classified into two categories based on location, whether it's focal hyperhidrosis or generalized. It affects the entire body. It could be associated with an underlying cause, in which case it's called secondary hyperhidrosis. My talk predominantly will be dealing with primary idiopathic focal hyperhidrosis, but it's important to consider the secondary causes of hyperhidrosis. I will briefly just go through them in this table. Essentially, it's important to rule out infective causes. It could be acute viral or bacterial infections, and especially chronic infections such as tuberculosis, malaria, and brucellosis. Hyperhidrosis can also be linked to recreational drug use, certain antibiotics, antiviral drugs, and antidepressants. Patients can get hyperhidrosis as a consequence of certain endocrine conditions such as diabetes, hyperthyroidism during pregnancy, at the menopause. It could be related to carcinoid hyperpituitarism and pheochromocytomas as well. It could also be related to underlying neurological conditions such as stroke, spinal cord injuries, and Parkinson's disease. And there are certain other conditions, the lymphoproliferative disorders, congestive cardiac failure, anxiety, and obesity. To understand hyperhidrosis, I'm going to take you back to a bit of anatomy and physiology. So sweat glands are plentiful in the human body. We have about 3 to 4 million sweat glands on us. They are essentially exocrine glands which secrete sweat. The sweat is actually formed in the pit of the gland and released by vesicles onto the skin. They are either ecrine or apocrine. Ecrine sweat glands release their secretions directly onto the surface of the skin. Apocrine glands release them through the hair follicles. Slight difference with the sweat production between the two glands as well. Ecrine sweat tends to be more watery, whereas apocrine sweat is a bit more thick and viscous. Ecrine glands are plentiful throughout the body, commonly seen in hands, feet, and the face. Apocrine glands are more common in the armpit and in the perineal regions. They respond to thermal, emotional, and gustatory stimuli and are regulated by the hypothalamus and the limbic system. They are innervated by the postganglionic sympathetic fibers, and the neurotransmitters involved with this regulation tends to be acetylcholine and other catecholamines. When patients have hyperhidrosis, they have a normal density of sweat glands, but the condition is related to increased production of sweat rather than an increased number of glands. Incidence is reported up to 3% in the UK, although I think the true incidence is probably a lot higher, and that's because patients don't tend to seek medical attention. Because it's such an embarrassing condition, or they may feel that it's normal, and patient education therefore is important. Hyperhidrosis tends to affect the armpits, the palms, soles, the face, and the groin area. It commonly starts during childhood or soon after puberty, but can affect at any age. There's almost a 50 to 60% positive family history associated with hyperhidrosis, and some studies even talk about a slight female preponderance. Hyperhidrosis can be quite an embarrassing and difficult condition and can lead to a reduced quality of life in patients, so much so that they may find even simple day-to-day activities like holding a pen, writing, working on a keyboard, activities such as exercise and dancing may be quite difficult, and it may lead to anxiety and depression. Some patients can present with bronchidrosis, which is essentially foul-smelling body odor related to sweat. It can also cause skin maceration, and patients sometimes can present with fungal and bacterial infections affecting these regions. History and examination wise, the history has to be aimed at eliciting the history of excessive sweating. Excessive sweating can be quite difficult to quantify, but the history has to target the location, the duration and frequency of these episodes of sweating. It's important to ask for a history of nocturnal sweating because that usually indicates there to be an underlying condition that's caused the hyperhidrosis. Patients can sometimes identify triggers, which could be emotional stress, excessive heat, but often we find that there are no triggers associated with primary idiopathic hyperhidrosis. And it's also important to rule out the underlying causes that I've alluded to during your history. Now, most physicians agree that hyperhidrosis can be diagnosed just on the basis of history and clinical exam. There are some tests available, such as the gravimetric testing and starch iodine minors test, which look at quantifying the amount of sweat produced, but these are not relatable to clinical practice, and their use is largely limited to research studies. Hyperhidrosis, the initial management involves lifestyle modifications, so talking to the patient about avoiding triggers and advising things like loose-fitting natural fiber clothing. There are antiperspirants available which will help with reduction of sweat, and these tend to be rich in aluminium salt. The idea is that they reduce sweat production within the gland themselves, and there are higher strength antiperspirants available on prescription, which should be trialed in the first instance. In the absence of a sustained response, there are treatments such as iontophoresis, which can be tried. Now, this is a method where the hands and feet are immersed in shallow tap water and a low voltage electric current is passed. The idea is that they affect the sweat glands at these locations and reduce sweat production. There are several commercially available iontophoresis machines available that patients can use at home. Typical treatment usually lasts about 25 to 30 minutes and have to be repeated 2 to 3 times per week. And once the patient has been established on a regime, they have to move on to a maintenance regime where they're doing this at least once a week. Results are not long-lasting. Patients will require or may require further treatments that may involve some anticholinergic drugs such as glycopyrrolate and oxybutynin. Now, these drugs are not licensed in primary care, but can be used under trial settings in secondary care. Botox is a product that can be injected locally and has good results that have been achieved with Botox. It involves intradermal injection into the sites of hyperhidrosis, primarily the axilla, but they've also been tried on plantar and palmar hyperhidrosis. Results are quite good, with effects lasting and staying for about 6 to 12 months. Botox can be repeated as and when required and has a high degree of patient satisfaction. That's how we do Botox injections. It's intradermal injection, as you can see in the picture here. Failing that, we could try something called thoracoscopic sympathectomy, which is actually quite an invasive procedure. It involves taking away the sympathetic chain at the T2 to T4 level. Most physicians now use a 2-incision approach, which is 2 small 2 to 5 millimeter incisions sent in the axilla to access the sympathetic chain. And this is what a thoracoscopic view looks like. You can see the sympathetic trunk here, and this is taken away. This is what NICE recommends, that patients who have persistent symptoms despite lifestyle modifications and 6 weeks of topical treatments should be referred on to secondary care for further management. Thank you. Any referrals or any comments, please feel free to email us at these addresses. Thank you for your attention.